Thank you very much for the introduction, and thank you very much for the invitation to talk today. The outline of my talk is really that I'm going to talk about obstructive sleep apnea and its relation to intermittent hypoxia and predominantly hypertension. Firstly, I'm going to talk a little bit about the background of what obstructive sleep apnea is and how it relates to hypertension. But then I'm going to go on and talk about experimental models of intermittent hypoxia and blood pressure before talking about our data from Oxford, where we looked at using a CPAP withdrawal model and supplemental oxygen and the impact of this on blood pressure. After this, I'm going to talk about some of the other potential sequelae of intermittent hypoxia and obstructive sleep apnea, looking at the effects of giving oxygen in this situation on the severity of sleep apnea measured by the apnea-hypopnea index, the effect on sleepiness, and finally a little bit of data about inflammation and intermittent hypoxia. So just to recap, obstructive sleep apnea is a very common condition and has several hallmark features. The diagram on the left really illustrates the predominant hallmark feature of cessation of airflow at night. So when a patient goes to sleep, the muscle tone is reduced around the upper airway dilator muscles, and the tongue narrows the space in the throat, and airflow stops. In addition to this, on the right, you can see the other hallmark feature, which is intermittent hypoxia. With these recurrent episodes of airway narrowing, you get recurrent dips in the oxygen saturations. What you can see on this all-night pulse oximetry tracing are sawtooth desaturations. At the end of an apneic event, typically events end in arousal. This leads on to the other feature, which is sleep fragmentation. Typically, we treat these patients with continuous positive airways pressure to reduce daytime sleepiness. One of the other common consequences or associations with sleep apnea is with blood pressure. And this is really very early data illustrating the relationship between obstructive sleep apnea and blood pressure. This is a case study with about 40 patients, and what you can see here is measured the severity of sleep apnea along the x-axis and blood pressure along the y-axis. During the sleeping period, there is a clear correlation between systolic and diastolic blood pressure and severity of obstructive sleep apnea. Likewise, there is a similar positive correlation during the waking period with blood pressure. Following on from this, in the year 2000, there are several seminal papers which looked at this relationship in more detail. This is data from a follow-on to the Wisconsin cohort study, which looked at longitudinal patients, around 700, and looked at new diagnosis of hypertension in these individuals. And what they showed here with this group, who have moderate or severe obstructive sleep apnea, in their fully adjusted model, there was really quite a marked increased risk of developing hypertension of around 3. Similarly, in the sleep heart health study with over 6,000 patients in a cross-sectional study, they showed this relationship with incident hypertension. This is data looking at 24-hour blood pressure profile in 44 patients and 44 controls from Oxford. And what this shows is this difference in blood pressure is most marked in the nocturnal period and in the early morning, with a so-called non-dipping pattern in blood pressure. I'm a clinician, and I'm interested in if this is something we can treat. Also, this is another important part of looking to see if this relationship is causal. And what this data does is to show the effect of CPAP on blood pressure. This was a 1-month study where patients were randomized to either CPAP or sham CPAP. These are all patients with significant obstructive sleep apnea and daytime sleepiness. And what you can see here is in the white circles, these are the patients on CPAP with sham, and the black circles represent those with CPAP. You can see there's a marked effect on blood pressure. This is most noticeable in the nocturnal period, but present throughout most of the day. What they went on to show was that in those patients with more significant obstructive sleep apnea, and therefore more significant intermittent hypoxia, there was a more marked effect of CPAP on blood pressure. This has now been looked at in several meta-analyses, and overall the effect of CPAP on blood pressure is about a 2 millimeters of mercury reduction in blood pressure. put this slide up because there are some patients who perhaps might get more of a response to CPAP in terms of blood pressure. This is data on patients who have resistant hypertension. So these are patients who have uncontrolled blood pressure despite being on 3 or more medications to control their blood pressure. And what they showed in this study was that there was a 3 or 4 millimeter rise, mercury reduction in blood pressure with CPAP treatment. So whilst this relationship is clear between obstructive sleep apnea and blood pressure, the underlying mechanisms that cause this raise in daytime blood pressure are not fully understood. There are really 2 competing theories. On the left, you have the theory of recurrent arousals, and recurrent arousals and sleep fragmentation could have effect on daytime blood pressure in a couple of ways. Firstly, there can be disturbed sleep architecture with a reduction in time spent in slow wave or REM sleep, and this in epidemiological studies has been linked independently of sleep apnea to a loss of that nocturnal dip in blood pressure and raised daytime blood pressure. Secondly, at the end of apneic events, patients arouse, and this arousal is associated with quite marked, in some cases, rises in blood pressure up to 70 or 80 millimeters of mercury. This is due to sympathetic activation and can lead to a hangover effect of raised daytime blood pressure. Separate from this hypothesis, there is a hypothesis that intermittent hypoxia in and of itself can lead to sympathetic activation and raised daytime blood pressure. It's well known that the acute blood pressure rises caused by arousal overnight are due to arousal and not due to intermittent hypoxia. What this study shows here is blood pressure in several patients during non-REM sleep overnight and following an apnea. The solid black bars represent apneas without supplemental oxygen, and the hatched bars represent apneas with supplemental oxygen coverage. Apneas without oxygen have a nadir saturation of around 70 to 80%, whereas those with supplemental oxygen all had a nadir in their oxygen saturations above 90%. And what you can quite clearly see in these individuals is that the supplementation with oxygen and abolition of intermittent hypoxia had no effect on the magnitude of the blood pressure surge following an arousal. What they went on to show was that actually you could induce a similar rise in blood pressure with other arousing stimulus, such as an auditory stimulus overnight. However, the effects of intermittent hypoxia on daytime blood pressure in OSA are less well established. There's good evidence from animal models that intermittent hypoxia has an effect on daytime or diurnal blood pressure, and this is work from Fletcher's group. In this model, rodents were exposed to intermittent hypoxia over 35 days, and their diurnal blood pressure was measured. And what you can see is after 30 and 35 days, there's a significant marked elevation in daytime or diurnal blood pressure. This effect was dependent on the carotid body, sympathetic nervous system, adrenal medulla, the renal artery, and the renin-angiotensin-aldosterone axis. So this gives a good idea about what might potentially be involved here. This work from the Grenoble group looked at 14 nights of intermittent hypoxia in healthy human volunteers and showed a similar effect. What you can see here on the top graph is at night 1, there's a marked rise in blood pressure following exposure to intermittent hypoxia in the daytime, and this is sustained at 13 days. Blood pressure levels were starting to return to normal after 5 days recovery. Interestingly, they didn't observe any difference in night-term blood pressure in this study. They correlated this increase in blood pressure to an increase in muscle sympathetic nervous activity. So these 2 studies give us an idea that intermittent hypoxia is potentially a key pathophysiological mechanism behind hypertension in OSA. However, there are some limitations behind these studies. They often use quite severe intermittent hypoxia, which does not reflect what we see in our clinical patients with obstructive sleep apnea, and they often don't model the hypercapnia we see during obstructive events. Another way of looking at this problem is by giving patients with obstructive sleep apnea supplemental oxygen to attenuate intermittent hypoxia and looking at the effect on blood pressure. Previously, there have been 2 randomized control trials which have looked and assessed the effect of oxygen in OSA on blood pressure in the daytime. And these 2 RCTs showed no significant improvement in blood pressure with oxygen. However, there were some limitations to these studies. They used relatively low flow rates of oxygen at 2 to 3 litres per minute, and excluded in the Gottlieb study the most sleepy and the most hypoxic patients. This is a 12-week study, and they thought it wasn't ethical not to allocate these patients to CPAP. So for good reason, they excluded these patients. They also had a fairly modest use of oxygen at about 4.8 hours per night through this study, and used ambulatory or office blood pressure in these studies. So what we set out to do was to look again at this using a slightly different model. And we looked to investigate the effects of supplemental oxygen versus sham on home morning blood pressure following 14 nights of CPAP withdrawal. I'll come back to what CPAP withdrawal is and how we use it as a model of sleep apnea. But importantly, we also aim to use a higher flow rate of oxygen, more likely to attenuate intermittent hypoxia, use home morning blood pressure monitoring, and by using a CPAP withdrawal methodology, we're likely to be able to include more severe patients with more significant hypoxia, and we're likely to include patients who are very compliant with therapy. So what is CPAP withdrawal? Well, this is a model which was really pioneered by Professor Kohler in Zurich and Professor Stradling in Oxford. And what's done in this model is that patients with known obstructive sleep apnea, moderate or severe in severity, who've been on CPAP treatment and are good users of CPAP for over a year, are recruited. We do some screening to make sure that their sleep apnea is well controlled on their CPAP, and to make sure that their sleep apnea is still present when they stop their CPAP. And we randomize patients over a 2-week period to either sham CPAP or continued therapeutic CPAP. And what you can see from this diagram is over days of the study that there's a rapid return in those allocated to sham of intermittent hypoxia and obstructive sleep apnea, whereas those patients allocated to therapeutic CPAP remain very well controlled throughout the trial period. In addition, in this model, we see very large rises in daytime morning blood pressure of 9.5 millimeters of mercury in systolic and 6 millimeters of mercury in diastolic blood pressure. We also see an increase in urinary catecholamines as a surrogate marker of sympathetic activation, and impaired endothelial dysfunction as a surrogate marker of cardiovascular disease. And what we went on to do was to design the supplemental oxygen during CPAP withdrawal trial. As I said, we screened patients to check that they were adequately controlled on their CPAP and their sleep apnea came back. We then washed them out back on their normal CPAP before bringing them along to visit 1, where they were randomized. At this randomization visit, they had a number of blood tests, questionnaires, and sleep maintenance of wakefulness test equivalent. Patients were then either randomized to 14 nights of oxygen instead of their CPAP, or 14 nights of sham instead of their CPAP. Throughout those 14 days of intervention, they measured their blood pressure and nightly pulse oximetry. On the penultimate night of the treatment arm, they measured a limited channel respiratory polygraphy sleep study. Patients then went back onto their CPAP for 14 nights before crossing over. We recruited 25 patients in this model. And our primary outcome was to look at the change in home morning blood pressure, oxygen versus air. We did this by looking at blood pressure in triplicate in the days prior to each visit. And we had a number of secondary and exploratory outcome measures, including the effect on pulse oximetry, sleep parameters, sleepiness, and exploratory parameters including venous base excess as a marker of daytime hypercapnia, apnea length, and some more exploratory analyses relating to inflammation. We recruited fairly typical patients for obstructive sleep apnea, so in their 60s, predominantly male, obese, and patients during screening had return of, on average, severe obstructive sleep apnea. As I mentioned in this model, patients have very good usage of CPAP and had very good hours of usage of oxygen and air throughout the trial. This is our primary outcome data. And what you can see here from the graphs is that on air from baseline to follow-up, there's a marked increase in systolic and diastolic blood pressure, and that supplemental oxygen therapy virtually abolishes the rise in systolic and diastolic blood pressure. The effect between groups is 6.6 millimeters of mercury reduction in blood pressure, oxygen versus air, and 4.6 millimeters of mercury reduction in diastolic blood pressure. Next, we wanted to go on and look and see why this might be. And due to some work from Andrew Wellman's group looking at loop gain, we were concerned that oxygen may be having an effect by actually reducing the number of obstructive events patients were having overnight. We heard already the concept of loop gain. This is the idea that some patients' obstructive sleep apnea is perpetuated by ventilatory instability. And these are just two schematics. On the top of an individual with theorized low loop gain, when they have an obstructive event, following on from this, they have a period of hyperventilation followed by hypoventilation, but this quickly settles out. Whereas in an individual with high loop gain, the ventilatory disturbance is perpetuated and can precipitate further obstructive events. Now, Andrew Wellman's group have shown that supplemental oxygen reduces loop gain in obstructive sleep apnea patients, and in combination with a sedating drug have shown that actually this reduces the severity of obstructive sleep apnea. These were, in this study, selected patients with relatively mild anatomic susceptibility, and we wanted to look at this in our patients. So on this slide, I've got data from the pulse oximetry looking at the effect on intermittent hypoxia and the effect on the apnea and hypopnea index from the respiratory polygraphy. What you can see from the graph here is that on air, there was a rapid return of intermittent hypoxia on night 1, where supplemental oxygen markedly attenuated intermittent hypoxia throughout the study, with a reduction in the median ODI from 32.5 to 6.4. However, we only saw a very small, non-significant reduction in the AHI in our study from 34.4 to 30.4. Similarly, we looked at heart rate rises as a surrogate of arousal and saw a small, significant reduction. We think that this marked attenuation of intermittent hypoxia is more likely to be the explanation for the blood pressure effect than this small effect on heart rate rises. This is a study from Kevin Gleason's group, which looked at what is the stimulus for ending an apnea. And this is actually a study in healthy volunteers, looking at different stimuli and seeing at what level of respiratory arousal respiratory effort, they cause an arousal. And what you can see is across individuals, regardless of whether the stimulus for arousal is hypoxia, hypocapnia, or resistive load, individuals wake up at similar levels of respiratory effort. This is potentially important in this area because if we are taking away this stimulus, you might theorize that apneas would become prolonged and patients may be more likely to become hypocapnic. And indeed, as others have shown, oxygen did indeed increase the apnea length. Now, we measured venous blood gases at patients' visits, so the venous base excess is probably more of a reliable marker than the venous PCO2. We saw with oxygen that there was an increase in venous base excess, which would suggest that there's an increase in hypocapnia with oxygen treatment. And overall, between groups, there was a marked effect on increasing venous base excess. You'll note at the end that patients, on average, were not hypocapnic by definition, but there was certainly an increase. I think it's also interesting to note that the patients who withdrew from CPAP onto air had a reduction in their base excess. And this is probably the reverse of a study that's been shown the opposite of this previously. And by that I mean, in this study, they looked at ventilatory responses to hypoxia in patients with obstructive sleep apnea at baseline and following 1 month of CPAP treatment. And what they showed in this study was that CPAP reduced the hypoxic ventilatory drive, where sham CPAP didn't. And probably whilst obstructive sleep apnea is returning in these individuals, there's an increased hypoxic drive to breathe, which is driving down their basic SES. Going on to talk about sleepiness. Now, sleepiness is often thought to be entirely due to arousal, but there is some data from animal experiments where mice were exposed to 8 weeks of intermittent hypoxia, which show that this leads to an increase in total sleep time, non-REM sleep time, and also a reduction in sleep latency. So for this reason, we were interested to see if supplemental oxygen in our study had any effect on sleepiness. We measured the Epworth Sleepiness Score as a subjective marker of sleepiness and saw significant rises in both treatment arms that were not statistically significantly different between the two arms. So here it seems that intermittent hypoxia is not the dominant cause of this returning sleepiness. We did look at this also with a maintenance of wakefulness test equivalent, but saw no difference in between the two groups here. In fact, if anything, the effects were in opposite directions between the subjective and objective measures. I've spoken a bit about sympathetic excitation. We did measure this in our study, but also one other theoretical consequence of intermittent hypoxia is inflammation and oxidative stress, which potentially could lead to cardiovascular disease. In our study, we looked at normetadrenaline, which is measured in the urine overnight, and saw increases in this in both arms. Whilst there was a reduction in the increase in normetadrenaline with supplemental oxygen, this was not significant between the two groups. We looked at high-sensitivity CRP as a marker of systemic inflammation, as this has been shown to be elevated in cohort studies of OSA patients, but found no between-groups difference here either. To go on and look at inflammation in a bit more detail, we've performed RNA sequencing on whole blood leukocytes from these individuals, and we saw a number of genes that were upregulated with CPAP withdrawal onto sham, which were not upregulated with CPAP withdrawal covered with supplemental oxygen. And looking at a pathways approach, we can see that actually some inflammatory pathways are upregulated with CPAP withdrawal onto air, but are not upregulated onto oxygen. This is exploratory data and is something that we're working with to understand more fully what this means. But I think what we can say at this point in time is that RNA sequencing can identify clear changes in gene expression following CPAP withdrawal, and that supplemental oxygen, and therefore attenuation of intermittent hypoxia, appears to downregulate some of these pathways. It doesn't downregulate all of these, so some of these pathways are probably related to other processes. And also as a note, there was also a suggestion that DNA repair pathways were upregulated, which potentially could point towards a deleterious effect of hyperoxia. So really, in summary, I'd like to say that supplemental oxygen markedly attenuates intermittent hypoxia and virtually abolishes the morning rise in blood pressure. In our patients, it did this independent of any effect on the apnea-hypopnea index, and in our patients over the short-term study had no effect on sleepiness. I think the mechanisms are not clear from our study, but some of the animal experimentation would suggest strongly towards an important role for the sympathetic nervous system. In the future, I think it would be interesting to evaluate and see if this has any therapeutic role. And I think a particularly important group, or interesting group, would be patients with resistant hypertension, particularly those who can't tolerate CPAP therapy. I think in any future study, one has to be mindful of the fact that we did see a rise in the CO2 and has to closely monitor this. And finally, I'd like to just thank my supervisor, Professor Stradling, and everyone else who's collaborated with me on this work and those who supported this research.
Thanks very much, Chris. Great talk. Any questions?
Thank you. It is very interesting. I wondered about the animal model for intermittent hypoxia, and does it make a difference if it is applied during the day or during the night or during the wakefulness or during well-defined sleep, and whether it has a different effect on whatever outcomes you're looking at.
So from my understanding, the models have applied this during sleep, which is daytime.
Are you sure about
rats. The one which I'm looking at here, I don't know about ones which have applied it during wakefulness in this.
So since you saw a little bit of hypocapnia, is that right?
Mm-hmm. Yes.
I'm wondering, did you see any change in respiratory rate, or some other aspects of breathing physiologies that could be important, or increased central apnea, maybe some hypercapnia, and then, some irregularity in breathing? Or
Sure. So looking at the sleep studies, we were doing a limited channel respiratory polygraphy, and in that respiratory polygraphy, we don't characterize with abdominal thoracic belts the difference between central and obstructive events. So we have an overall AHI rather than splitting it in that means. And we didn't measure daytime respiratory parameters such as respiratory rate.
But even if you just look at respiratory rate just through the night, do you see...
I haven't looked at that. There's something we could look at and see if it's increased.
I briefly saw the slide, so maybe I'm wrong, but I had the feeling that the Epworth sleepiness score were very low, no? They were not really very sleepy. They were in the 8, 9, right?
Correct, but these patients were on CPAP treatment at baseline and were they only had their CPAP stopped for 2 weeks.
Well, still, very quickly you become again sleepy, so
I think it's a self-selected population, though, the patients who are willing to go through CPAP withdrawal, and actually patients who become very sleepy rapidly wouldn't be willing to go through this protocol. So we're selecting a population of patients who are perhaps somewhat resistant to sleepiness over the shorter term at least. But these... We had the
Osler.
We have an MWT equivalent.
No. Ils ont fait du Osler. They did Osler. It's
we did the Osler, which is MWT equivalent, which did deteriorate over the time period, and was pretty normal at baseline.
But you know that there's still an interesting question about the fact that if you phenotype patients who have cardiovascular consequences, sleep apnea, and no sleepiness, versus the one who have sleepiness, it's maybe a different phenotype, and that would be...
These certainly are not patients with no sleepiness. These are patients taken from the sleep clinic who've been on CPAP for many years and were started on it from a tertiary referral centre who had sleepiness at baseline. But it's just that they've been on CPAP for many years. This is not a non-sleepy population.
Okay, look at the difference between sleep quality, restorative sleep, and sleepiness. Maybe you might find some gradual complaints. It might refine the results. Interesting.
Any other questions? You said that Osler did deteriorate.
Yes. In both groups over the trial period. We didn't see a significant difference between oxygen and air, but there was a significant deterioration from baseline to 2-week follow-up.
This wasn't all done around the time that the DVLA rules got stricter and patients were wary of declaring sleepiness.
So it was done after the change in regulations, but patients were informed of the risk if they were to become sleepy, such as that it would impair their safe driving, to let us know, and we could book them a taxi to their visit or withdraw them from the study. We only had to withdraw one patient for that reason from the study.
Right, well, if there are no more questions, I'd like you to join me in thanking all 4 speakers for a great session.